Hello, everyone from the virtual universe. My name is Guy Carmelli. For those of you who don't know me, I'm an assistant professor at the University of Massachusetts. So today I want to talk to you about the deliberate apprenticeship model for scheduling your medical students throughout your department. I first heard about this at USC, and then I piloted it at Kings County and SUNY Downstate when I was there as a way to kind of increase engagement and learning through our department. Before I continue, I want to give special thanks to Doctors On, Gottlieb, Fan, Wagner, and Willis for kind of helping me, guiding me through this topic. So the targets for our short little talk, first we'll look into several different learning theories that give credence to deliberate apprenticeship. Next, I'm going to talk about some of the benefits of deliberate apprenticeship relative to that of a standard rotation. And then finally, I'm going to talk about how I piloted deliberate apprenticeship and how you could incorporate deliberate apprenticeship into your medical student schedule. So I'll begin with the hypothetical. So tell me or think to yourself if this is something that's happened to you. You're working clinically and a medical student shows up, they're assigned to you for the day. So you ask them, what do you want to get from today? And they're like, oh, I really want to suture a person. And you're like, I've never seen you suture. I don't know your skill level. How about this? You watch me do one, and then I'll let you do the next one. And so the first one comes in, and they're watching you lacerate on the arm as you're explaining stuff. But then the shift goes by, and not another laceration comes in until like the end of the shift when you see one. Oh, well, this one's on the face, and I'm not really comfortable letting a student suture this delicate area. Maybe I'll like have them like put one in and I can like help them. But the end of the shift occurs and they didn't really get to do one. So you say, I'm sorry, but maybe the next time we work together, I'll let you do one on your own. But lo and behold, you never work with this student again, and they show up the next shift with a new attending, and they're like, so what do you want to learn on this shift? And the process begins all over again. So this is an example of a failed see one, do one, teach one. The student needs consistent guidance in order to progress through their learning. So let me hone my inner best man. The Oxford Dictionary defines apprentice as a learner of a craft bound to serve and entitled to instruction by their employer for a specified period of time. In other words, it's a relationship between a master and a novice in order to learn a specific professional practice. So this is William Osler, and he didn't just invent nodes. He was actually a great educator and saw a lot of benefits to bedside teaching and actually, teaching amongst with your learners at, in the practice. And so he kind of would prefer that over asynchronous types of learning or classroom learning. However, things have changed in the field of medicine since the days of Dr. Osler. You see, while classically medicine had been taught utilizing apprenticeship model, as hospital waiting rooms grew, became busier, we needed to train more and more doctors. Patients started to dislike the idea of being trained by young student physicians and requesting more attendings. So we had to move our students to the lecture halls. The erosion to the time-served methods of apprenticeship has created a challenge for us educators trying to prepare our future physicians. This isn't necessarily true in other fields of medicine, such as on the wards or in surgery, where they still use apprenticeship models with students. However, it hasn't really entered into the ED setting yet. But to Dr. Osler's point, the ED is a prime location to have an apprenticeship model. Because like outside the emergency department, students rarely have the opportunity to talk to undifferentiated patients or create their own management and treatment plans or have some sort of autonomy over medical care that they provide. Also, EM compared to other fields is less structured. It's very chaotic work environment. So adding some sort of structure through an apprenticeship model is ideal for helping a student navigate through issues that may arise. So this is where I want to introduce the term deliberate apprenticeship. I first heard this term, or I read about it in a paper in 2014 by Iyer et al. And it's basically a deliberate apprenticeship relationship just doesn't occur by chance, but rather it requires purpose and consistency. The learner must know what's expected of them in order to be able to meet those expectations so that they can succeed. So, in emergency medicine, deliberate apprenticeship means that a student must be assigned to the same senior resident or attending for a given specified period of time. And so I said I noticed this at USC. So at USC, they assign their medical students to a specified senior resident for about 1 to 2 weeks at a time. And I mirrored this when I piloted at Kings County when I was there. All right. So I'm a med ed geek, so I can't give a lecture without giving some sort of education theory, right? So let's discuss a couple concepts that give credence to why a deliberate apprenticeship model works and why you should incorporate it into your medical student rotation at your department. So apprenticeship has otherwise been described as a legitimate peripheral participation. What this means is getting student involved in service as much as current regulations permit. We're not asking a learner to learn just by watching us. This isn't self-directed learning where you help the learner identify their own learning needs. Rather, this is building an important chemistry between our teacher and learner to get them actively involved in their own education. Now, the reason a legitimate peripheral participation leads to learning is due to the theory of learning that is situated learning. So here, unlike behavioral and cognitive theories of learning, which could occur independently or in a classroom, situated learning has a social cultural basis and occurs with active participation within a society or a community. Situated learning holds that effective education requires learning that is embedded in authentic contexts of practice. Therefore, through deliberate apprenticeship, a learner can feel safe to get involved in increasingly more complex tasks to enrich their learning with shared expectations from a constant master or supervisor. So now, this participation in the learning cannot occur in a vacuum. We need a proper setting to do this. Just like the phrase, it takes a village to raise a child, so too does it take a community of practice to grow a new learner. Communities of practice are groups of people who share a concern or a passion about something that they do, and they learn how to do it better as they interact together regularly. So let's get back to apprenticeship. As we stated, apprenticeship is usually considered to be a single relationship between a master and a novice. However, things are a little bit more complex than that, as optimal learning occurs within a community and setting that the learning experience is framed in. In fact, you can take the apprentice relationship and insert it into the living curriculum put forth within a dedicated community of practice in order to advance in overall learning and engagement. So this brings us back to how this can be done in emergency medicine. All right, I can't see anyone, but raise your hands anyway if this is how your medical student EM rotation schedule looks like. Now, this is a typical student schedule where each day a student is assigned to work with a different provider without any clear consistencies. They're in their fast track, and then they're in their resuscitation, and they're at the community side, and then they work a night shift, and every day is like a different kind of person that they're working with. While you may provide some legitimate peripheral participation and you could attempt to build a brief apprenticeship, especially if you get lucky and you work with the same person twice, the student has no clear, consistent community of practice to build upon. I imagine you can begin to see some problems with this. The student may have different expectations each shift, different setting, different presentation and treatment styles, poor evaluation and feedback, less opportunities for more advanced procedures and cases. So, like I keep saying, students need consistency to help learn and grow, and deliberate apprenticeship can help with this. So, that's the learning theory aspect. So, I want to get into the nitty gritty of why I believe of what are some of the benefits that deliberate apprenticeship could offer for you and your learners. Okay, so deliberate apprenticeship could provide better supervision, better for the patients and for their safety, and allows for graded responsibility. You know, we all love graded responsibility, scaffolding, these kinds of terms for our students so that we can watch them progress. This, we know lots of evidence shows that it's good at helping in overall learning and autonomy. Next, another benefit is what's called a near peer mentorship or relationship. Here, a student can build a relationship with a resident or a faculty. So, beyond just the teaching and learning benefits that occur with deliberate apprenticeship, there is a relationship that forms between the novice and master, which comes with it both coaching, trust, mentorship, and friendship. Multiple studies have looked at the many benefits of the near peer relationship. One can relate to the shared experience and offer up specific guidance. This relationship takes time and cannot occur over the course of a single shift. Progress towards proficiency requires evaluation of current performance coupled with suggestions of further development and improvement. Much of this process takes place at the bedside as the educator and student evaluate the patient. Daily evaluations can be combined with summative end of clerkship evaluations to provide both real-time and overall assessment of a student's performance. It is also helpful for providing narrative feedback to use in the MSPE. Now, we've all had trouble evaluating a student that we have had very little interaction with. Deliberate apprenticeship offers an opportunity to have more rich data in which to provide meaningful information to our students. So there's some existing research showing the benefits of apprenticeship, allowing students to have a better experience and understandings of their expectations. This is the study I mentioned before by Ayers et al., comparing the experience of two sets of students rotating into a third year PEDS emergency medicine experience. One of the group used a standard schedule, like I showed before, where they had a different team every shift, while the other used a deliberate apprenticeship schedule. By pairing students with senior residents who not only oriented the students, but also closely engaged the students, deliberate apprenticeship enhanced student perception of their own learning. Furthermore, students who were actively engaged during their PEDS-ED shifts commented on having better individual experiences. In particular, comments on student level of inclusion with residents and/or faculty alluded to the idea that deliberate apprenticeship increases participation in the unique clinical environment of the PEDS-ER. Like I said before, I similarly piloted this at my shop and compared the experiences of evaluations of students who underwent 2 consecutive experiences. They first did a rotation with the standard schedule, and then the second one utilized the deliberate apprenticeship model. We presented this pilot as a poster presentation, and while we did not reach the power needed for statistical significance, the comments that people gave for the rotation for deliberate apprenticeship schedule were so glowing as to suggest its success. Some of the students loved being paired with the same resident and building a relationship. Others like to feel integrated into the team and getting to know each other. So these are some of the comments. So how does this work? Well, you pick 1 or 2 weeks and assign a student to work with the clinical schedule of either a senior resident or an attending. If you have a templated resident or attending schedule, this makes things easy as you can just fit in the students into the already templated schedule. At USC, the residents were always scheduled to work 2 weeks of day shifts and then 2 weeks of night shifts. So it was more or less regulated that you could just fit in a student into like a block of night shifts or a block of day shifts. And this also allows, if you're working resident with student, for the residents to act as teachers for the new students. Now you have the residents and attendings both providing summative during their time together and formative feedback after the dedicated time together. You can also schedule separate time or shifts on top of this with dedicated education leadership. So if some of the students are EM bound, you can schedule separate shifts with the clerkship directors or the APDs or the program director and so on and so forth. And this will allow EM bound students to get more exposure to the program and to make it easier to write the SLOEs. Now, performing deliberate apprenticeship at your shop isn't necessarily easy. There are some challenges that you may have to overcome, mainly in scheduling. A large number of students from a required clerkship may make this a challenge. Furthermore, if your institution does not use a templated resident or faculty schedule, then you might have to do some of the work by hand in order to try to give students equitable amounts of undesirable shifts, which is our nights and weekends and holidays. Whether
Dr.
it is done
Carmelli?
by you, yeah?
I'm sorry, we have 2 minutes left. I was wondering if you want to take any audience questions or if you want to continue with the content.
This is like the last slide, so I'll just
Perfect.
finish up and
Okay.
we'll get to you.
Sure.
So one thing you could do is use a spreadsheet to collate totals and or move 1 to 2 shifts around as needed. Allowing students to trade shifts with each other is another way to kind of make it feel like they have more control and try to alleviate some of the perceived inequalities. But whatever the amount of time it takes to kind of put these schedules together, I think it is definitely worth the reward that deliberate apprenticeship offers. And so I really want to thank, and I'll open up to questions and hope that I've encouraged some of you guys to want to do deliberate apprenticeship at your shops.
All right, Guy, the question with the model from Saurabh Kandawal, with the model of their metrics shift to shift that are expected from the student. So which other are there metrics that change from shift to shift or week to week? I guess.
What do you mean by metrics?
Well, maybe maybe I can kind of be more specific. Like week to week, are you expecting students to progress in their history taking, in their physical examinations, on their procedural skills? I'm just assuming this in a very deliberate practice model. So comparing deliberate practice to deliberate apprenticeship is, how do you know students are getting better week to week with this model versus end of a rotation feedback that says that they like it better?
Yeah, so I mean, the truth is right now there's no data that proves that there is actual learning benefits, which is why I want to encourage more people to do this so we can like more easily study it. But we know from other research that that good feedback is one way people improve, and you just don't get as good feedback when you have people that don't know the learners. And the more growth through scaffolding, which means gradually letting students do more and more as you decrease your amount of oversight, also kind of helps them improve. So logically, being able to work with the learner more often, give more feedback, let them do more and more complex situations does make sense to lead to learning. But I haven't seen any specific studies for deliberate apprenticeship in medical students, though this is in other fields. But you know, like every time you work together with a student, a different attending would say, you know, I like things this way, so present to me in this way, or I like, these are the questions I want you to ask. And so a student will never get good at something when every time a different attending kind of tells them, this is what I want you to do. And then the next shift they have to like restart. So being able to work together in a dedicated time allows you to kind of at least get really good at one way of doing things. And then hopefully over the course of 4 weeks, if you have 4 different instructors or 3 different instructors, then you kind of can get a little more variety.
All right. Dr. Carmelli, thank you very much. Clearly this resonated. Lots of thanks in the chat. I'm sure people are going to be emailing you about how to actually make the scheduling work. Would that be okay? Do you have an email that they can contact you at?
Sure. I'll put it in the chat.
Thank you. All right. Actually, let's put it at. All right.
Oh, I typed it wrong because I was going so quickly.
That's okay. To the full group.
Oh, that makes sense. All right.
I think this is has huge potential. Congratulations.
Thank you.
You're welcome.